Welcome, everyone, and thank you for joining me today. I'm excited to present to you on the topic of comprehensive chest imaging in respiratory medicine. The full title is Comprehensive Chest Imaging in Respiratory Medicine: Techniques, Applications, and Safety in Diagnosing and Managing Lung Diseases. In this session, we'll explore the various imaging techniques used, how they apply to different lung conditions, and important safety considerations. So, let's dive in and discover how these imaging methods play a crucial role in respiratory care. Now, let's explore the techniques we use in thoracic visualization. These are vital because they give us visual insights into the structures within the chest, which in turn helps us make informed clinical decisions. Understanding these techniques is key to effective respiratory care. Moving on, the significance of chest imaging cannot be overstated. It's absolutely essential in diagnosing and managing lung diseases. Whether it's detecting an infection, a tumor, or structural abnormalities, chest imaging provides the critical information we need to guide treatment. Finally, let's talk about the role of radiographic evaluation. This remains a cornerstone in our field because it offers quick and accessible insights into lung pathology. It's often the first step in assessment and helps us monitor how patients respond to treatment. Overall, radiography is a fundamental tool that supports our clinical decision-making every day. Let's take a closer look at how a radiograph is produced. It all begins with the discovery of X-rays by Wilhelm Röntgen back in 1895, a groundbreaking moment that revolutionized medical imaging. The actual production of the radiograph involves a process where a cathode stream interacts with an anode target inside a sealed vacuum tube. When the electrons from the cathode hit the anode, energy is transformed into X-rays. These X-rays then exit the tube through a window, pass through the patient's body, and cast a shadow onto an image cassette. This shadow contains the information we need to visualize the internal structures. Originally, this process relied on film to capture the images, which was the standard for many years. However, with advancements in technology, digital radiography has become the norm today. This allows us to create images using computers, offering much clearer images and more efficient workflows, ultimately improving patient care. Understanding this process helps us appreciate the technological evolution behind the chest imaging we use in respiratory medicine. Let's talk about X-ray penetration, which is fundamental to understanding chest imaging. X-rays penetrate matter differently depending on the tissue density and thickness. That means denser tissues, like bones, absorb more X-rays, while less dense areas, such as air-filled lungs, allow more X-rays to pass through. Now, these less dense or radiolucent areas, think of the lungs filled with air, appear darker or black on the radiograph because they absorb fewer X-rays. This contrast helps us distinguish different structures within the chest. Moving on to the characteristics of a chest radiograph, it's important to remember that radiographs give us a two-dimensional image of a three-dimensional anatomy. So sometimes, this can obscure the true spatial relationships of structures, which is a key limitation to keep in mind. Finally, the structures that absorb more X-rays, like bones, these are radiopaque, appear white or light on the image. Recognizing these differences in radiolucent and radiopaque areas is crucial for accurate interpretation of chest images in respiratory medicine. Let's talk about comprehensive chest imaging in respiratory medicine, focusing on slide 5. First, chest radiographs are essential for assessing patients after invasive procedures. They help us quickly evaluate what's happening in the lungs without delay, so treatment decisions aren't held up while waiting for detailed image interpretations. Next, these radiographs are invaluable for monitoring changes in lung disease over time. By comparing images taken at different points, we can track disease progression or response to therapy. Another key point is that chest radiographs help us identify the positions of tubes and catheters. Correct placement is crucial for effective treatment and patient safety, and imaging provides that visual confirmation. They also play a vital role in evaluating how well our treatments are working. If the lung condition improves or worsens, the radiograph helps us see those changes clearly. Furthermore, chest radiographs guide us in making appropriate therapy decisions. They inform whether we need to adjust medications, consider additional interventions, or continue current management. Finally, these images are used to detect lung alterations caused by various disease processes. Recognizing these changes early can significantly impact patient outcomes. So overall, chest radiographs are a versatile tool, integral to post-procedural assessment, ongoing monitoring, device placement, evaluating treatment effectiveness, guiding therapy, and detecting disease-related lung changes. Let's take a closer look at the different radiographic views used in respiratory medicine, starting with the tools we use to identify pneumothorax. Expiratory views are particularly helpful here because they can reveal air in the pleural space that might not be visible on a standard inspiration film. Moving on, when we need to detect pleural fluid, the lateral decubitus view becomes very useful. In this position, the patient lies on their side with the side of concern against the image receptor. This setup provides us with a good depth perspective, making it easier to see if fluid has accumulated in the pleural space. Now let's discuss the lateral view. In this case, the film cassette is placed behind the patient. This view is commonly used for portable X-rays, especially in critical care settings. However, it can sometimes complicate interpretation because of magnification effects and the positioning of the patient, so we need to be cautious. Next, we have the anteroposterior, or AP view, where the film cassette is placed in front of the chest. This view is often used when the patient cannot stand, like in an emergency or ICU setting. In contrast, the posteroanterior, or PA view, involves placing the cassette behind the patient. This is generally preferred because it minimizes cardiac magnification and provides clearer, more accurate images of the chest structures. In summary, understanding these various radiographic views, AP, PA, lateral, and lateral decubitus, is crucial. Each has its specific indications and limitations, and selecting the right view helps us better evaluate the lungs and chest in different clinical scenarios. Now, let's move on to the systematic evaluation of chest radiographs, which is a crucial step in respiratory medicine. First, we need to confirm the patient's positioning. This involves checking that the spinous processes are centered within the tracheal shadow, which helps us ensure the X-ray isn't rotated. No rotation means we're looking at an accurate view of the chest structures. Next, we assess the X-ray penetration. Remember, denser structures like bones appear lighter on the film, while normal lung tissue appears darker, but with visible vascular markings. This contrast helps us evaluate the lung fields effectively. Then, we look for abnormalities. For instance, patchy white areas can indicate consolidation, often seen in infections or other pathologies. Increased density in certain areas should catch our eye as a potential sign of disease. Finally, it's essential to review all thoracic structures thoroughly. Following a structured approach ensures we don't miss anything important. Systematic evaluation like this is key to accurate interpretation and ultimately, better patient care. Now, let's take a closer look at some key radiographic signs we use in respiratory medicine. First, the air bronchogram. This is when you can see the air-filled bronchi outlined against the surrounding alveolar consolidation. It's an important sign because it helps us confirm the presence of intrapulmonary disease, such as pneumonia. When you see this pattern, it indicates that the alveoli are filled with fluid or other material, but the bronchi remain air-filled and visible. Next, we have the silhouette sign. This occurs when the normal borders between neighboring structures of different densities are lost. For example, if the heart border becomes obscured by a lung infiltrate, it suggests that the pathology is in direct contact with that structure. This sign is very useful because it helps us localize the abnormality within the lung. Both of these signs, the silhouette sign and air bronchogram, play a crucial role in our diagnostic process. They assist us in differentiating between various types of lung abnormalities and help pinpoint their exact location. Recognizing these signs improves our ability to interpret radiographs accurately and ultimately guides our clinical decisions. Let's take a closer look at some key findings we see in chest imaging related to respiratory conditions. First, atelectasis, which is essentially lung collapse. On imaging, you'll notice an increased density in the affected area, and often you'll see the trachea and mediastinum shift toward that same side. Additionally, the hemodiaphragm on that side may appear elevated, giving us clues about the underlying process. Moving on to pneumothorax, this is when air enters the pleural space, leading to the collapse of the lung. On the scan, you'll often see a visible pleural line where the lung tissue retracts away from the chest wall. This is a hallmark sign that indicates a pneumothorax has occurred. Now let's discuss tension pneumothorax, which is an emergency. Here, air gets trapped under pressure within the pleural space, and this pressure can impair cardiac filling. The result can be severe, causing both respiratory and cardiovascular failure if not treated promptly. Finally, hyperinflation is commonly seen in obstructive lung diseases like COPD. On imaging, you'll notice an increased anterior-posterior diameter of the chest, a flattened diaphragm, and an enlarged retrosternal airspace. Recognizing these features helps us understand the extent of hyperinflation and its impact on lung function. All of these imaging findings are crucial for accurately diagnosing and managing respiratory diseases, and understanding these patterns allows us to connect what we see on scans with the patient's clinical picture. Now, let's discuss post-procedural chest radiograph evaluation, specifically focusing on endotracheal tube positioning. When we look at these X-rays, you'll notice the radiopaque strip along the tube, which helps us visualize its exact location inside the airway. It's crucial that the tip of the endotracheal tube is placed about 3 to 5 centimeters above the carina, the point where the trachea splits into the bronchi. Proper positioning here is vital because if the tube is too low, it can lead to complications like right mainstem intubation, where the tube goes into the right lung too deeply, or even esophageal intubation, which is obviously a serious concern. The purpose of doing these chest X-rays after procedures like intubation is to make sure the tube is correctly positioned and to ensure patient safety. It's a quick but essential check to prevent complications and ensure proper ventilation. Sometimes, the tube might need to be repositioned or secured more effectively. The X-ray helps us determine if adjustments are necessary to keep everything in the optimal place. Finally, follow-up imaging is equally important. It allows us to continuously monitor the tube's position over time, especially after initial placement, to ensure ongoing safety and proper function throughout the patient's recovery. This ongoing vigilance is a key part of comprehensive respiratory care. Now, let's look at some of the technological advances in CT imaging that have really transformed respiratory medicine. One of the key features is the rotating X-ray beam, which allows us to generate three-dimensional images with remarkable detail. The slices are typically just 1 to 2 millimeters thick, giving us high-resolution images that help us see fine anatomical structures clearly. This advancement has significantly improved our ability to diagnose and evaluate various lung conditions. Moving on to the applications, CT scans are incredibly versatile. They're used to detect lung tumors, which is vital for early cancer diagnosis. They help identify pulmonary embolisms, which are life-threatening blood clots in the lungs. CT imaging is also invaluable for assessing interstitial lung diseases, pneumonias, occupational lung diseases, COPD, and emphysema. Essentially, whenever there's a complex or subtle lung issue, CT can provide detailed insights that other imaging methods might miss. However, while CT scans offer these powerful benefits, they do come with some drawbacks. The major concern is the exposure to significant radiation, which is higher than what we get from standard chest X-rays. This increased radiation dose is something we need to consider carefully, especially when ordering multiple scans or for vulnerable patient groups. So, while CT is a fantastic tool in our imaging arsenal, we must balance its diagnostic advantages with the potential risks associated with radiation exposure. Now, let's talk about some of the challenges we face with MRI imaging for the lungs. One of the main issues is that both respiratory and cardiac movements can cause motion artifacts, which can really degrade the quality of the images. This makes it more difficult to get clear, accurate pictures of the lung tissue. Additionally, because MRI uses strong magnetic fields, there are important safety considerations, not just for patients, but also for the medical staff working around these machines. Safety protocols need to be strictly followed to prevent accidents. Moving on to the limitations, these motion artifacts are a significant hurdle because they can blur or distort the images, making diagnosis more challenging. That's why special precautions are necessary, especially for respiratory therapists who might be accompanying patients into the MRI unit. The strong magnetic fields require them to take extra care to avoid any risks. Despite these challenges, MRI still holds potential, particularly in certain cases. For example, when we want to avoid exposing patients to radiation, MRI can be a valuable alternative. It's not always the first choice, but in specific situations, it can provide crucial information without the risks associated with X-rays or CT scans. Overall, while there are hurdles to overcome, MRI remains a useful tool in our respiratory medicine arsenal, especially when we weigh the benefits against the limitations. Now, let's take a closer look at chest ultrasound applications. One of the key uses is evaluating cardiac function through echocardiography, which allows us to assess how well the heart is working. It's also very helpful for guiding procedures, such as ensuring the correct placement of an endotracheal tube. Moving on to lung and pleural assessments. Ultrasound is excellent for evaluating lung consolidations that we might see on radiographs, and it can clearly visualize pleural effusions and pneumothorax, which are critical in respiratory emergencies. Ultrasound guidance is also invaluable during procedures like thoracentesis, chest tube insertion, or central line placement. It helps us be precise and safe, reducing complications. Another major advantage is portability. These devices are small and portable, meaning we can bring them right to the bedside for quick assessments, which is essential in urgent situations. And we must emphasize that ultrasound is completely safe. It's harmless to humans, including fetuses, making it a reliable tool even in pregnancy. Finally, a quick note on how ultrasound works. It uses sound waves reflected differently by various tissues to create images, offering several benefits over other imaging modalities, such as safety, real-time imaging, and portability. All these features make chest ultrasound an essential part of respiratory medicine, helping us diagnose and treat patients more effectively and safely. Let's take a closer look at fluoroscopy in chest imaging and its important applications in medical procedures. Fluoroscopy is commonly used during procedures like cardiac catheterization, bronchoscopy, and various invasive interventions. Its main feature is a continuous X-ray beam that passes through the patient's body, allowing us to see live images in real time. This dynamic imaging technique is incredibly valuable because it provides real-time guidance and assessment during procedures. Whether we're navigating catheters or guiding instruments, fluoroscopy helps us see exactly what's happening as it happens. The key benefit here is real-time guidance. It supports clinicians by giving them live imaging support during interventions, which enhances precision and safety. So, in the context of respiratory medicine, fluoroscopy is an essential tool that bridges imaging and intervention, making complex procedures safer and more effective. Now, let's talk about some important safety measures in respiratory medicine, particularly related to chest imaging. Healthcare workers must wear dosimeters to monitor their exposure to radiation. This helps ensure that their exposure stays within safe limits. For pregnant staff, special precautions are essential to protect both the mother and the fetus from unnecessary radiation exposure. Moving on to monitoring and precautions, it's vital to minimize the time spent near radiation sources whenever possible. The less time you spend near these sources, the lower your dose will be. Additionally, increasing your distance from the source can significantly reduce exposure, Doubling your distance can cut exposure by about 75%. That's a huge reduction. Shielding also plays a key role. Using lead aprons, thyroid shields, and radiation safety glasses provides an extra layer of protection, especially during procedures involving higher doses. Speaking of doses, it's important to recognize that an annual exposure above 100 millisieverts is considered dangerous. This threshold helps us identify when radiation exposure becomes a health risk. In advanced imaging techniques like CT scans and PET scans, the doses involved are higher compared to standard X-rays. This means we need to be more cautious with these procedures. For routine chest X-rays, the radiation dose is relatively low, about 0.06 to 0.1 millisieverts. To put that into perspective, it's roughly 2 to 3% of the natural background radiation we're all exposed to in the US every year. Finally, radiation exposure comes from both natural sources, like cosmic rays and soil, and man-made sources, such as medical imaging. Understanding these sources helps us better manage and minimize exposure in clinical practice. By applying these principles, we can ensure safety while still benefiting from the essential imaging techniques that support respiratory diagnosis and treatment.